Well, welcome. Thank you all for coming this evening. As Deb mentioned, my name is Dr. Tina Robakiewicz. I've actually been connected with the Milford healthcare system now since 1991. I've had many roles here at the hospital, initially as a resident in training from UMass, and then transitioning to primary care within the system. I was a primary care doctor for about 9 years before transitioning to hospital medicine and ultimately finding that my real passion was in really focusing on patient-centered care. And that's really what palliative care is all about. With me tonight is Kim Morse, who is the physician assistant from our palliative care team here at the hospital. Kim actually comes to us from Rhode Island, where she had years of experience with Hospice of Rhode Island. So she has met with patients and families in various settings, including the hospital setting, the skilled nursing facility setting, as well as the home setting. So we're very fortunate to bring her on board to be part of our team here with her broad base of experience. So our topic tonight, Your Life Now at Its Best. The focus is on palliative care, what it is, why it's come into existence, what it has to offer for patients and family, all kinds of details. And then towards the end, Kim is going to focus a little bit more on advanced care planning for individuals. And then we will open it up for any questions that you have. Well, first of all, what is palliative care? Well, the definition is that it's a medical subspecialty which focuses on preventing, treating, and relieving pain and other debilitating effects of serious and chronic illness. But let's break that down a little bit. So it certainly is a medical subspecialty. And when people think about medical subspecialties, I think they usually think of the more traditional subspecialties, things like cardiology, which focuses on the heart, or pulmonary, which focuses on the lung, gastroenterology, which is focusing on the abdomen, the liver. But it's interesting because as healthcare has been changing rapidly over the last number of decades, there have been new medical subspecialties that have come into existence. One of them back in the 1980s is emergency medicine, which didn't really exist in the first half of that century. In the 1990s, hospital medicine became a new specialty, which is one of the most rapidly growing specialties across the nation. Following soon behind it was palliative medicine as well, and as a specialty, there are specific training programs for it, and there is board certification for hospice and palliative medicine. Although in the past, it was possible as an experienced physician like myself, through life's experience, through interacting with patients throughout my career, there have been other physicians like myself who have done some additional training and courses and have been able to grandfather in terms of having board certification. From the year 2012 onwards, any physician who is board certified in hospice and palliative medicine will have needed to go through an official approved training program. It is a specialty that oversees a broad range of illnesses. When we talk about the serious and chronic illness, we're talking about processes that occur in all the different organ systems, whether it be the nervous system, the heart, the lungs, you name it, any of those illnesses are what we deal with. And the focus is really on trying to relieve any of the symptoms that are a result of the illness itself, whether it be pain or other symptoms that we'll talk about. So why has it come into existence? Why was there a need for it? What's been going on? Well, one of the first things that we can state is that it's probably come into existence because people are living longer. The life expectancy has increased by 30 years from the decade of 1900, from 1900 to 2000. Back in 1900, the average life expectancy was 47 years. By 2000, the average life expectancy was 77. Now, there are certainly many modern advancements that have had an impact. Probably one of the most important has been our ability to treat infections with antibiotics so that people aren't dying in childhood or early in life. But certainly there have been many other developments in terms of treatment for cancer or heart disease or other things that in years past people would have been diagnosed with, and that would have been ultimately what soon afterwards caused their death. People are living longer, and our bodies end up sustaining a lot of wear and tear through the years as well. And with that, we're going to be diagnosed with medical conditions, whether it be arthritis, heart failure, emphysema, or dementia, many others. And because we have so many individuals who are living longer, they're going to be experiencing the symptoms related to their illness, and we want to be able to relieve their symptoms so that they can enjoy a good quality of life for as long as possible. Just a few of the statistics. At this point in time, it's estimated that about 90 million Americans are living with serious and chronic illness, and that number is just going to increase as the population continues to age. It's estimated that by 2020, there are going to be 157 million patients with at least one chronic illness. And as it is today, 7 out of 10 Americans are dying from complications of a chronic disease. So it's really important for patients, for families of an individual who has a chronic illness to have a good understanding of what to expect from that process. If they don't have a good expectation or an understanding of what to expect, then they may make choices that are not going to provide a lot of benefit or may subject them to unnecessary suffering. When we talk about treatment, often we talk about weighing the possible benefits of a treatment versus the burdens or the side effects of the treatment. The other thing that we need to keep in mind is that there are many individuals who don't have just one process going on. There are many who have multiple illnesses, multiple diseases, and sometimes it's a matter of trying to balance out the different organ systems or the different issues that are going on, and it's important that there's good communication among all of the specialists who are involved so that any recommendations that are being made are not going to have a harmful impact on some other process that's going on. Another reason why we need palliative care is that prior to this, there was a definite gap. Patients, and I'll use the example of cancer, if patients were receiving active treatment for cancer, then they were receiving active treatment for cancer. And then once the treatment was no longer beneficial, once they were at the end of the life, once there was consideration for end-of-life care, then the active treatment stopped, and all of a sudden there was the focus on comfort. It's been felt that there really needs to be much more of a continuum. We need to be able to start focusing on symptoms much earlier in the process and not ignore the symptoms that someone's having until the very end of life. All right, so palliative care versus hospice. This is one of the issues that I think most individuals have difficulty understanding, and even individuals in healthcare, because a lot of times people will equate palliative care with hospice. But in reality, hospice is just a small subset of palliative care. And it's that amount of palliative care that's provided at the end of a person's life, in the last weeks to months of a person's life. In order to qualify for hospice, a patient needs to have a life expectancy of 6 months or less. And at that point in time, there needs to be the specific decision to stop curative treatment and instead to transition the focus to comfort. On the other hand, palliative care is appropriate at any point in a person's chronic disease or illness. So from the time somebody is diagnosed with an illness, they could be appropriate for palliative care. There are no prognostic requirements. There's no life expectancy requirements that are necessary in order for someone to qualify for palliative care. And the key thing is that palliative care can be provided at the same time as a patient is receiving active curative treatment for their underlying disease or process. So there's no longer the need to choose between either treating the illness or treating the symptoms that are burdensome. So with palliative care being out there and as a specialty, there have been an increasing number of studies looking at the benefits of palliative care and documenting that it is something that's worthwhile for patients and families. There have been studies that have shown that palliative care programs effectively relieve pain as well as other distressing symptoms for patients. There are also studies that look specifically at patient and family satisfaction regarding their care, and when a palliative care team is involved, the satisfaction rating increases. There are also studies looking at the benefits of palliative care at the time of transitions. Transitions mean changing locations. So for instance, a patient is in the hospital for an acute problem and transitions out to a rehab facility or transitions from the hospital home. There needs to be that communication with the primary care doctor, with the other doctors that also care for the patient. And by having the palliative care team involved, transitions are easier, they improve. This other point that we have here is an interesting article that was published in the New England Journal of Medicine in 2010, and it was comparing patients who received traditional treatment versus those receiving early intervention with palliative care. And in those populations, the patients who received the early intervention with palliative care actually were less depressed. They scored that they had an improved quality of life. And interestingly enough, those patients actually lived longer. They lived 3 months longer when they received palliative care than when the focus was on the active treatment for the underlying process. Now, it's not clear why that occurred. There are certainly many theories. One is that by having the palliative care focus, that there's less stress, so less release of stress hormones, and maybe that has some impact in terms of improving a patient's overall survival. But I suspect we may be seeing more studies like that, just highlighting the potential benefits of palliative care. So what type of diseases or illnesses, what types of patients may benefit from palliative care? Well, as I mentioned, pretty much any organ system with the diseases are possible. Ones that we commonly see include cancer, COPD or emphysema, congestive heart failure, dementia, kidney failure, liver failure, but the list can go on and on. Patients with Parkinson's disease, multisystem atrophy, valvular heart disease, patients with other lung processes like pulmonary hypertension or fibrosis. We are involved with many, many different types of illnesses. And the patients can experience many different types of symptoms. I think probably most common a symptom is pain that we'll be involved with. but also shortness of breath, intractable nausea, fatigue, loss of appetite, weight loss, difficulty sleeping, weakness, all of these things that can have a real impact in terms of a patient's quality of life. So, as the palliative care consult team, what do we do? Well, when we get notified about a consult, the first thing that we need to do is gather information. And so we'll gather information from the patient's medical records here at the hospital. We will outreach to outpatient records, having access to Dana-Farber across the street, to the centricity records for the Tri-County doctors, Reliant Clinic, we have access, and certainly we speak directly with the primary care doctors whenever appropriate, and we speak as well to the specialists who are involved. It's the gathering the information to get a good picture of the patient's medical history and what the active issues are. The next step is meeting with the patient and doing a very thorough history and exam. But with the history, the main focus is trying to sort out what symptoms the patient is experiencing. And by doing so, and knowing now all of what's been going on from a medical standpoint, a lot of times we can then make recommendations that are very specific to that individual patient regarding treatment options that may benefit, that may help to relieve the symptoms that they've been experiencing. Now, in addition to meeting with the patient, the other key group that's involved is the patient's family as well. This is very much a patient-centered approach, but the patient is most often part of a family unit. And I'll use family to mean more of a general term as well, not just relatives, but sometimes the family are close friends and other loved ones. Often they're looped in terms of the values and the opinions that the patient is expressing, because part of our conversations as well focus around what the patient values, what their goals of care are, because recommendations may change depending on that. For instance, if we have an individual whose main goal is to live as long as possible, there's some type of event that's occurring, a few months from now, then in that circumstance, a recommendation may be to continue with active treatment for, a particular process. On the other hand, some patients focus much more on their independence. For them, quality of life is being able to live independently in the community, and the thought of living in a skilled nursing facility or dependent on others is a life that they would not want to consider. And that's important information that we need to take into consideration as we're making recommendations. So we're trying to match the patient's goals of care with the treatment options that are available. And it's helping families to set clear goals and helping to support them with these difficult decisions. Not everyone is going to make the same decision in the same circumstance. We have individuals who, definitely want to go ahead and receive dialysis for their end-stage kidney disease. We have other patients who just are not interested. That's not part of a life that they've ever envisioned, and sometimes it's difficult for them letting their loved ones know that they don't want the dialysis, and that's okay. We can continue to support them, providing relief of symptoms with those choices that they've made. In addition to that, we also help to identify additional support services in the community. Because again, they're not going to be living in the hospital, they're going to be transitioning out, and we want to make sure that it's a safe and a successful transition back into the community. So making sure that we're utilizing potential resources, visiting nurses, physical therapy, other resources in the community. Part of our role is to enhance the coordination of care and communication. After we've had these lengthy conversations with the patient, with the family, Our next conversations are with all of the other specialists that are on the team, making sure that everybody has a clear understanding of what the patient's wishes are, what their goals are, and making sure that everybody is, following along with that. We do provide ongoing support throughout their hospital stay, provide education regarding the disease processes, and when appropriate, sometimes help to link families to bereavement services. So Kim and I are just a small part of the team because it really is a large multidisciplinary team that's involved with the patient's care. And after we do our initial assessment, most often we start to loop in the key members of the team as needed. Certainly one of the key members of the team is likely going to be the primary healthcare provider and having the communication with that individual in the community. But there are also the social workers at the hospital, case managers, chaplains, because spirituality, religion is very important for an individual's whole health, the pharmacist, nutritionist, and as we mentioned before, certainly the families and loved ones. From a patient's perspective, then, palliative care is going to be key to relieving distressing symptoms. It's going to allow the patient to have relief of symptoms at the same time that they have ongoing treatment. It's going to help them to choose care options that fit their goals. It's going to help navigating a very complex and very confusing medical system. Helps the patient and families to understand what options are available and what the pros and cons are of the options, and also just provides support, both practical as well as emotional support. So some key concepts before I turn things over to Kim. The bottom line is that it's appropriate for patients with all types of chronic illness. It's to help patients and their families maintain a good quality of life and manage the burden of the disease. It's to help to reduce suffering throughout the course of the disease, appropriate from the time of diagnosis until the end of life. Again, assisting patients and families with advanced care planning that Kim will talk about further. You don't need to have a life expectancy of 6 months or less in order to have palliative care. It is appropriate at any point along the course of the progressive chronic disease. And with that, I will pass the microphone.
Oh, I don't need it.
Oh, you don't have.
Okay. So as Dr. Robakiewicz had mentioned, we spend a large portion of our time meeting with patients and their family members, and we dedicate a good chunk of it to talking about advanced care planning. We know at any age a medical crisis can leave someone too ill to make his or her own healthcare decisions. And making healthcare plans for the future is an important step in making sure that a patient gets the medical care that they want, even when other people are making decisions for them. According to a recent study on the Consultation project, it stated that there was 60% of people had stated that they felt that their family making a healthcare decision for them would be burdensome without having had a previous discussion in regards to what their wishes are. However, only 56% of people had actually discussed their wishes with their family members. So it's something that's extremely important to discuss before a crisis happens. What one did you?
Oh, sorry.
Down. No, thanks. So we know that 1 in 4 older Americans will have to make healthcare choices at the end of their life that they're unable to do based on advanced disease processes, dementia, and at that point, someone else will have to step in and help assist with those decisions, which makes it really important to have the conversations earlier. Learning about the types of decisions that might need to be made, considering those decisions ahead of time with family members, letting others know about preferences, and completing an advance directive. So an advance directive is a legal document that goes into effect if a patient is incapacitated and unable to speak for him or herself. A living will is a written document that a patient has that states what their wishes would be in certain situations, what they would want, what they wouldn't want, time frames associated with it. A durable power of attorney for healthcare is a legal document listing a healthcare proxy, which is someone that a patient chooses to make decisions for them if they're unable to make those decisions. And it's very important that a patient and their healthcare proxy have had discussions so the proxy is familiar with the wishes that the patient would want. During advanced care planning and during the discussions that we have with patients and their family members, we discuss decisions that could come up near death. And those can include, but are not limited to, CPR, cardiopulmonary resuscitation, ventilator use, artificial nutrition or hydration, and that could be with IV fluids or feeding tubes, and comfort care. So recently there have been a lot of resources, both in the community and online, to help patients and their families start talking about their wishes and their advanced directives. And one of them is the Consultation project. It was started in 2010 by Ellen Goodman. Has anyone heard about that before? You have. So she started the project in her home, sitting at the kitchen table with colleagues, chaplains, nurses, and they all started discussing their families and good deaths and bad deaths that they had been surrounded around. And by doing so, their hope was to have the conversation start much earlier at the kitchen table in homes versus waiting until the advanced stages in the intensive care unit when someone was in a crisis. So information for the Consultation project is online. And one of the most important things is when it comes to the end of life, I want mine to be. So they have an outline that you can print off and have those discussions at home with family members and then bring into your primary care physician or to the hospital as well. Here in Massachusetts, we have medical orders for life-sustaining treatment, and I did give everyone a copy sample to look at. So that's a legal document that is signed between a patient and a provider. Can be done here in the hospital, in a skilled nursing facility, in a primary care office. And it goes into detail in regards to what a patient's wishes would be. CPR, ventilation, artificial hydration, or nutrition, and for how long, whether or not that they would want to be transferred to the hospital, if they would consider dialysis as a means of treatment. And once that has been signed by both the patient and the physician, it becomes part of the medical record, and it is legalized so it can transition with a patient to home or to a skilled nursing facility or a long-term care facility and be valid. However, if a patient decides that they've changed their mind at any time, a new form can be completed and the old form is null and void. We're starting to bring this into our hospital here. So when someone comes in through the emergency department, often the discussions start based on what would you want in the situation should things worsen, or at the end of your life, have you started thinking about how you would envision that? And you'll notice that these forms are going to become more widespread. So Aging with Dignity in 5 Wishes. I'm not sure, I have some copies here to pass out if anyone is interested, but this came about in 1997. There are 18 million copies nationwide, and it's the one that's used the most because it's easy to read, easy to fill out. 42 states have legalized this copy if it's signed. So the 5 wishes, the questions outlined. The first, the person I want to make healthcare decisions for me when I can't. Could also be a healthcare proxy, an advocate, an agent. The kind of medical treatment I want or do not want, and that can include the CPR, intubation, artificial nutrition, dialysis. How comfortable I want to be includes the use of medications for pain, anxiety, restlessness, oxygen. How I want people to treat me, and what I want my loved ones to know. So at this time, I just wanted to take one of the personal stories off of the Conversation Project.org to share with you, because I think it's important to get a good feeling for the type of patients that we may see here in the hospital and the discussions that we have and how they can be beneficial. So this is Going Home, and it's written by a healthcare provider in a clinic as she's seeing a patient for the 13th time. When I first laid eyes on Marilyn, I don't think she will survive another week. 89 years old, with short, curly gray hair, she sits in a wheelchair and manages a smile. According to the nursing sheet, she weighs 109 pounds. She wears a bulky white sweater over her gray dress, both too big for her frail body. Her ankles dangle, swollen due to worsening heart failure. Although depressed, she manages a smile. Her daughter sits beside her, hands clasped in her lap, as she awaits the team's assessment. Marilyn has been hospitalized 4 times in the past year for heart failure. She has had 5 chest x-rays, 4 echocardiograms, 1 CAT scan of her chest, and open heart surgery to replace her mitral and aortic valves. She has spent many weeks of the past year in nursing homes. She has been seen 13 times in the clinic, and she has not had the strength to walk in over a year. In a different time, before the advent of modern drugs, tests, and procedures, Marilyn would have been recognized as a woman who is dying, a woman who had lived many years but now had reached the twilight of her life. She would have rested peacefully at home with her family beside her until she passed. Today, however, there is always more we can do. Because we can treat the pieces of Marilyn's condition, we believe the whole may be salvable. Thus, despite all the care she has received, all of the doctors, the tests, the medications, no one has told her she is dying. My assessment today that she is dying is based on a careful review of her condition and the treatment options available. Marilyn has advanced heart failure and kidney disease. She has chronic anemia and bleeding. She is frail, which is a well-described marker of a poor prognosis, and she has become more frail every time that she has been in the hospital. She frequently develops wet lungs and swollen ankles from failure. Her condition is unresponsive to oral medications at home, and treatment of her heart failure requires coming to the hospital and many days of IV diuretics. This tethers her to an IV pole, restricting her mobility and shrinking her already dwindling muscle mass. It would be very easy to tell her that she can be treated, recommending a 5th hospitalization for the year, a course that would lead to more tests and medications. She would be unhappy, but she would accept it as she trusts the medical team and she looks to them for guidance. Another hospitalization would likely not improve her life in any significant way. If we accept that Marilyn has a limited number of days remaining, a 5th hospitalization would force her to spend her precious days among strangers, away from home in a sterile hospital setting. She would have to remove her clothing, putting on a hospital gown. An IV would be placed, which is a procedure that has caused her pain and bruising in the past. The well-intentioned nurses and doctors would continue to cause discomfort by prodding her belly and her legs. During a time when her life spirit should be celebrated, it would instead be marginalized. We chose a different path. With kindness, compassion, and respect, we tell Marilyn that she is dying. We explain the multiple advanced conditions affecting her body. We tell her that further curative treatment, while always an option, has a low likelihood of meaningful results and may make her feel worse. We encourage her to think about her goals. If these are your final days, how do you want to spend them? That one question. We explain that although her condition may be terminal, her symptoms can be relieved. She does not have to suffer any longer. As it turns out, Marilyn was not surprised by anything that we had to say. She was a sharp and intelligent woman, and she knew her aged body was nearing the end. She was thankful for the honesty and turning from us, she looked longingly at her daughter. She clasped her hands into her daughter's and asked to be taken home. So I think that's one of the powerful stories that Dr. Robakiewicz and I can share with you every day with patients and families that we meet. And that's why it's so important to discuss advanced care planning from the very beginning and not wait until a crisis occurs. So a couple of myths and misconceptions with palliative medicine that we've discussed throughout the presentation. Palliative care is not needed until the last weeks or months of life. And the truth, palliative care is available and recommended at any time during a chronic illness. There are no prognostic requirements, and earlier involvement has shown increased satisfaction for not only patients, but also their loved ones. Myth, you have to give up your personal physician to have palliative care. Well, we talked at length about the palliative care team, and that also includes primary healthcare providers. And so we are consultants on that team, and we always consult with the primary provider who will remain involved in a patient's care until the very end. Palliative care means giving up hope. We each wear a button that actually says HOPE, palliative care, because we believe that palliative care provides hope for the best quality of life possible, a hope for being comfortable and without pain or symptom burden. So just want to thank you all for your time, for coming out on a Tuesday evening at 7 o'clock to learn more about something that we're passionate about, and we'll open it up to any questions. I'm just going to come here.
I can speak pretty loudly, but my question is, how often do you get referrals from the hospital to your palliative care program?
Often.
Right. Actually, at this point in starting up the palliative care program, it is available for patients who are in the hospital, who are they're hospitalized at this time. The program has taken off, and we have been much busier than initially anticipated. I think word is getting out regarding all of the possible benefits that palliative care has to offer.
So are you finding the majority of your patient or your referrals are, do you get a lot from the Dana-Farber Cancer Center, or are you getting a lot from a variety of others?
We see patients every day coming from the emergency department, the intensive care unit, the floors, and also with Dana-Farber. We work pretty closely with the oncologists and often see their patients to help with goals of care and symptom management.
And then just in regards to the conversation, there was a program that was on, I forget whether it was 60 Minutes or 2020 or one of the other programs. They had a thing all about the conversation until the family was sitting down. They had started talking about it. The daughter started bringing it up to her about her father, who was 85, and they started talking about it. And it was a large family. There were all ages there, and when the father started talking about it, then some of the kids who were like, maybe in their 20s, they started bringing up. They started saying, well, geez, if I was in that situation, if this was me, they started saying how they would want to, if they were ever in a situation at their age, this is what they would want. And it really became quite a lively conversation for all of them. So it was very, very good.
I think in primary care nowadays, it's often being discussed earlier, as it should, with physical exams, with your provider, someone that you're comfortable with, and typically you're seeing them often, at least yearly. So those discussions are much easier when they start to take place with someone that you have developed a relationship with, and when there is not a crisis situation going on. And I think that often, unfortunately, we're seeing patients come into the emergency department in crisis mode, and unfortunately those conversations have not yet been started. So they're taken aback. Why am I being asked this now? Yeah. So our hope is for more education in earlier conversations around the kitchen table with family members versus in the intensive care unit.
And it does really relieve a lot of that burden from the family, because we do see family members of individuals who can't speak for themselves, who are on life support in the intensive care unit, and the family is struggling. They don't know what the patient would want in this circumstance, and part of them feels guilty if they consider the option of removing life support, and yet they realize that, you know, the person has little quality of life on life support, and it may be something that's being looked at long term because it doesn't look like it's possible to successfully get the person off of life support. So having the conversations can really help to relieve that burden that inadvertently gets placed on family members.
I actually have a question. We talked before about doing this in an outpatient setting. I know right now we're doing it in an inpatient setting, but what's the goal for the time frame to be doing it in an outpatient setting?
So yes, we needed to start somewhere, and so we focused our resources in the hospital, but we've already started having conversations and looking at potential sites, so that, at least to begin with, the goal would be trying to be able to see the inpatients that we see in follow-up in the outpatient setting, and then as time progressed and we had more resources, having referrals from the primary care doctors in the community as well. And I anticipate that that's going to occur over the next year or two.
How do you transition this from here into the community? And do you work closely with the hospice, the VNAs, et cetera?
Yeah. Just last week, we actually met with several local hospices and VNAs to learn a little bit more about their services. We often see patients here that we do transition home with services, bridge services with palliative medicine versus hospice care, and we want to be sure that we have the most up-to-date information on the resources that are available for those patients. But again, I think more education to our community here at the hospital, to the primary care physicians local, to talk about what we can offer them in terms of helping with symptom management for patients, at least patients that we're seeing here in the hospital, and maybe starting on a regimen for pain or anxiety and shortness of breath to make sure that it continues on the outpatient setting.
No, I would agree that there's definitely that handoff that occurs directly to the primary care doctor. You know, we do the assessment here, we make our recommendations, and when the patient's ready to transition out of the hospital, there's the phone call to the primary care provider to say, look, we've done this thorough assessment, this is what we're recommending. Do you feel comfortable with taking over the plan at this point? And the answer thus far is consistently yes.
I have another question. If you had somebody, if it was somebody with metastatic disease, cancer, but they're not at a point where they've been given, 6 months to live, at what point in that process does this become valuable for that patient? Does it have to be a point where, treatments are starting to fail and their pain is starting to come, or?
Well, there are some people, and actually there are some outpatient cancer sites where as soon as the patient is diagnosed with the cancer, they also have a visit with the palliative care specialist, with the idea that over time, ideally if things go well, there's just an intermittent meeting with the palliative care specialist, but if the patient starts to develop burdensome symptoms, whether it be pain, shortness of breath, then the amount of time spent with the palliative care provider and the focus over time may increase towards palliation, towards relief of symptoms, whereas the focus over time regarding curative treatment may start to shrink. but we definitely like that continuum, that overlap. And it's also really good, I think, for individuals with chronic disease, getting to know the palliative care team as early as possible, because you do develop that relationship as well, and it makes it that much easier over time.
Now, have you experienced any, I know you say you turn it over to the PCP. How have the PCPs been with this? Because, you know, my patient, your patient.
No, actually,
No.
so far, the feedback from the primary care doctors has been incredibly positive. In fact, the question that I usually get asked is, okay, how soon are you going to be seeing patients in the community? And it's really more a matter of resources, and, you know, we need to be certain that we have appropriate resources, because we want to be able to provide the intensive service, the patient-centered focus to each individual, and you can't skip.
Can't rush that.
Yeah.
No.
No, we usually expect that with any initial consult, it's at least 2 hours, if not much more than that.
Anybody on the team here?
Do you see patients in consult every day in the hospital, including weekends?
Right now, we've not been seeing the patients on the weekends because, again, of our limited resources. But again, we check in frequently, even when we're not in the hospital. And a lot of times, in anticipation of the weekend, we have the plan outlined. We've spoken with the team. You know, they have plans, you know, A, B, C, depending on how things go. But it's not uncommon for us to be off on the weekend and checking into the hospital and quickly trying to get an idea of what's been going on, so that if it looks like there's anything that we should intervene on, we do.
How long has the program been in place here?
Since last summer.
Yeah, and we started with maybe 1 consult a day, and some days now we're up to 4, 5, 6 new consults. Besides seeing patients, we keep them on in follow-up on our service as well.
Has healthcare reform impacted your program at all?
Well, that's a
think so.
loaded question.
Go ahead, Tina.
Not obviously. Actually, it's very interesting, because with palliative care, during prior elections had been made very political. And Sarah Palin talking about death squads, death panels, was completely taking out of context what was there, because what was recommended was that primary care doctors be allowed to have these conversations with their patients. It was nothing to do with ending life prematurely, and it was very sad that it was used politically as a tool against opponents. I think that caused a significant setback for palliative care, and, you know, hoping as we go forward that politicians, people in the public eye, appropriately present information, because this is something that is so important to each individual's health care.
Is palliative care covered by Medicare?
Mhm.
Oh.
Yes.
Yep, just like any of the other medical subspecialties, the cost of the consultation is covered.
Who takes the referral? Who refers the patient to you? Is it the primary care physician, or can a social worker go to you and say, would you consider this
So-
a person? Or?
So currently, in our hospital system, in order for any consult to take place, there needs to be a physician order. So typically, that order comes from one of the physicians caring for the patient in the hospital. And yet, we certainly encourage anyone involved with the patient, the family, other members of the team. If they feel that a palliative care consult is beneficial, we encourage them to speak up and to have that conversation with the physician caring for them in the hospital. Because usually once there's an understanding that this is something that is desired, it's unusual to have anyone say, oh, no, we're not going to do that.
And often there are multidisciplinary rounds here at the hospital every day, including the physicians discussing the patients with the primary nurse caring for them, the social worker, the chaplain, the pharmacist, and at that time, we often hear about referrals.
I have one more question. It seems like some of the stuff I heard in the late 80s, early 90s of, directives and end-of-life directives, do you find that people really have not talked about that? Is that more people have not talked about it than have talked about it, do you think?
Yeah.
Yeah, I think these are difficult conversations. I think in our society, we don't tend to talk about death. I mean, I think in our American society, we think that death doesn't exist, or, there's always going to be some medical treatment, something that's going to take care of the problem. I hope that we will start to have more and more conversations about the end of life and, about what any particular individual would want or wouldn't want as part of their care.